So the hemodynamics and CRRT, okay, this is something that is very important. So I'm going to actually tell you what exactly you have taken so you restart the entire thing. Restart. So first of all, there is no real hardcore, robust, super class 1, grade 1 evidence on this topic. First of all, there is nothing that evidence-based medicine can give you when it comes to renal replacement therapy and hemodynamic calculations. There is nothing. So at the end of the day, when we want to deep dive into our RRT, we need to look at systematic review and meta-analysis. And if in fact there is only one systematic review that suggests that there is limited evidence with respect to any particular intervention's efficacy. There is only one. One systematic review suggests that there is limited evidence, okay, in mitigating hemodynamic instability in critical patients across RRTs, okay, and this is the one. Okay, this Douglas did one meta-analysis, and what he figured out over here was just this two database, these two in CRRT. You see, so the entire thing is intermittent hemodialysis. There is sustained low efficiency radiodialysis, and there is CRRT. So there are only two papers which actually talk about CRRT and hemodynamic instabilities. There are only two papers, okay. And in those two papers, one is a single center study that is done in Spanish in France, and the other one is an Australian single center study. So there are very small, limited data. So when you look at data, we're looking at data that is multicentric, we're looking at data that is prospective, we're looking at data that is interventional to actually call it evidence-based data. But here you have an observational study in 2012 and another one on the same year in Australia. They have another observational study. One is 30 patients, and here is some 21 patients. There are very few data that actually explained about what hemodynamic embarrassment is all about. So there are two data, just two, okay, two. So that is why when you talk about CRRT, it all depends on experience. It all depends on your evidence. It all depends on what you've done so many years. You cannot one fine day get up and say I'm going to start CRRT. It doesn't make sense. Okay. So how do we do it? So how do we do this? So are we worried in the first place? Are you worried? If there is hemodynamic embarrassment?
Yes.
Why? Why are you worried?
We should maintain.
Why? Why?
So basically, controls will be in our hands.
Organ perfusion already gone. What are we looking at organ perfusion?
Controls will be in our hands, so we can.
No, the answer is this. Okay, mortality. The answer is mortality and myocardial infarctions. There are two things that occur in these cases. So if you look at this is the association of hypotension with mortality, association of hypotension with cardiac dysfunction. Okay, so look at this. What happens is as you go from 85 MAP to 55 MAP, the odds ratio for dying of getting myocardial infarction becomes high. Similarly, when you go for mortality, look at the odds ratio from 85 to 55, it actually goes very high, almost doubles. Okay, so the point is, if you have hypotension, you don't treat it by NORAD and dopamine, you still have mortality. You treat it by NORAD dopamine, you still have mortality. The issue is this. The issue is not having treated. Any Tom, Dick and Harry will just start NORAD and dopamine and say, "Arey, wow, we've maintained." They are not maintained. This patient is still going to die. You understand? Because the moment you create a hypotension, the chances of dying are going to be on the higher side. And of course, if you're looking at patients who are going to be in, you are salvaging. For example, we had that patient whom we were trying to salvage, isn't it? Who died. So in that case, you want to salvage the kidney. At that stage, if there is hypotension, irrespective of that, there is going to be acute kidney injury. At the end of the day, what happens to these patients? They have acute tubular necrosis, and then they go into myocardial infarction, and then the mortality that actually goes higher. So having hypotension is not a problem. In fact, if you think that it is 1 hour or 2 hour hypotension, nothing will happen. No, it depends on that also. Look at this time period averages of less than mean blood pressure less than 65. If you are even 8 minutes, or hours. These are hours actually. The hours. Okay, you can have a rise in mortality just in some hours. Okay, in some hours also. So there is a definite rise in mortality the moment there is going to be hypotension. So you can't really. So is it common? So we talk about hemodynamic instability that we can avoid by doing CRRT, but is it really common in CRRT? That's the next question you have to answer. Okay, we know that it is dangerous, but is it common? Okay, is it common? So if you look at this study, this is the study that was done among electronic health records in the United States. They took up all the electronic health records in the United States and they looked at what happens. They've got a very robust system to understand every patient in the ICU, every patient in the hospital is actually on a system, and that system can be accessed all across the country. Okay, you can access it. So when they look at the electronic database, when they looked at serious adverse events, they actually look at serious adverse events and put it up. You can actually read it, anyone can read it. So when you go to serious adverse events, you see the first hour hypotension is the maximum, 43%. You understand? Apart from significant hypothermia, the most important thing that you're basically seeing on the highest is the first hour of hypotension. Very, very important. So it is definitely, so this is best practice in the guidelines, investigators. Another large number of investigators, almost 15 years ago, they looked at worldwide practice to understand what is their commonest side effect. That was US. This is worldwide. Okay, so in worldwide, again, what did they find? Hypotension, 18.8% compared to everything else. So worldwide hypotension was seen maximally in CRRT patients. Okay, it's very clear. Among this, if you look at this, it's very, very common. What do you understand from this? That it is increasing mortality, and the second thing is very common. It's very common to cause this. Okay, now this is something that we did, isn't it? This is our study. In our study, what we did, we actually looked at intradialytic hypotension. We did that. And what did we found? We found the same situation that at 10 minutes, 10 to 15 minutes, if we don't take care of it, we are actually getting hypotension over here. Okay, so you can see the SVR dropping tremendously at 10 minutes. You can see this? It drops tremendously by 10 minutes. Okay, so there is definite hypotension that we are getting. This is data that comes from our hospital. It's not something that is this is from our hospital data actually showing that there is a drop in blood pressure, mean arterial pressure. Alright, so this is another analysis that actually looks at those patients who basically had CRRT done, and there, even if you added dopamine or noradrenaline, there is no change in mortality. Mortality still is present. Okay, so in short, hypotension is bad. It's not the treatment of hypotension. Hypotension is bad. You cannot have hypotension. That is problematic. Right? So what is the right target? So at the end of the day, what would be the right target? If there is hypotension, what I have to avoid, I need a number, right? A number to say this is hypotension. So what is the right target then? So what we know from this study is, as the MAP is less than 82.7, the cumulative survival rate, if it goes, it starts actually going up and up. If you keep the MAP above 82.7, it looks like that. It looks like that, at least in this graph, which is a CRRT, it's a data that was done 1 year back in Japan, where they looked at all the patients who underwent CRRT. And what they found was large number, they did more than 20,000 patients here. And what did they find? That if the MAP was kept more than 82.7, the cumulative survival is going up. So there seems to be some number that is slowly generating. What we've understood is that it's non-linear also. So even at 82.7, you start improving. They are more than 120, or you should just go up higher and higher on the mean arterial pressure. More than 110 you go, there's also a problem. So 82.7 seems to be pretty good, but if you go more than 110, there is a problem. You might think that, okay, if the blood pressure is low, that's fine. I'll raise it up, I'll raise it even more higher. This is what you think, right? To improve mortality. No, if you raise it even more higher, there is a problem. So there is a very thin line between causing patient to die and letting patient to be alive. Okay, that's very important. The blood pressure target during CRRT thus needs to be personalized. Okay, it needs to be personalized. So the target seems to be not very clear. That's why it needs to be personalized. And that's why if you see when we do CRRT, we're looking at lactate, we're looking at capital refill time, looking at a whole lot of things that is personalized on this. And what is this terminology? HIRRT, hemodynamic instability and renal replacement therapy. This is what exactly she mentions. Systolic blood pressure of more than 20 plus symptoms, or a MAP drop of more than 10 millimeters of mercury. But why does the BP go down? First of all, why does it go down in the first place? If CRRT was supposed to be for unstable patients, why is the BP going down? In intermittent hemodialysis, you can understand you're giving UIF, you're taking 1000 ml, or you're doing 3.5 liters and 4 liters and all. But why is it going down? So there are a large number of reasons why it will go down. There is right from excess ultrafiltration, temperature alteration, cardiac causes, QV, QR, mode, vasopressor clearance, rapid output issues, and dialysis blood flow. We go to each one of them. Okay, commonest reason for a CRRT is fluid overload. The common reason why we do a CRRT is fluid overload. Okay, you have a patient who will resuscitated for the last 3-4 days, and then 5th day, 6th day has cumulative balance of 6 liters. I said 20% more than intake output what you have is supposed to be positive balance, and that will actually cause patient to die. So that's why commonest reason why we do ultrafiltration or CRRT is because there is fluid overload. This is the commonest reason. Alright, this is very clear. The common reason is fluid overload. But too much of a good thing is not good. But too much of ultrafiltration is definitely not good. That is why maybe it's the excess ultrafiltration that we sometimes do. Okay, for example, when we are removing blood, when we're removing fluid from there, what is actually happening? Interstitial fluid is coming inside at the rate of 13 ml per kilogram per hour. Okay, and then this is actually compensating inside. Because of this compensation, the patient's blood pressure doesn't fall. But what happens if you increase the UF? If you increase it maximally, this time period that it takes for it to approximate from the interstitial glycocalyx or the interstitial fluid may not be adequate enough for it to cause maintain the hemodynamics, and that's probably the reason that we have to ensure that the UF is not very high. But which of these patients will actually suffer from this problem, from UF related issues? That we should know. Okay, so which are those patients? This is the first patient, higher PVPI. Okay, what is PVPI? Pulmonary vascular permeability index. When we do hemodilution, we get a PVPI. Okay, the PVPI, when it is high, pulmonary vascular permeability index, if it is high, somewhere around 3, there is going to be a chance that this patient will suffer from hemodynamic embarrassment as a result of UF. As a result of UF. Those patients who are on IPPV with high PEEP, when I say high PEEP more than 8, okay, so those patients who are on IPPV with, especially with high PEEP, they will have a problem. All critically ill patients can have an issue here. And those patients who have vascular dysfunction, that's why I said it will an echo, a vascular dysfunction and identified vascular dysfunction is very, very important. Okay, that is very, very important. And that's probably the data that we're going to take in the next study of ours. Okay, alright. So, what is preload dependence? Okay, preload dependence is the PLR induced rise of cardiac index, which will also predict an HIRRT. How? So, I do have all these things. Say, for example, I have all these things. I want to do CRRT. Most of our patients will have all these things, right? Most of our patients are going to have most of these things. They're going to have vascular dysfunction. They're going to have patients on ventilators. They're going to have patients on high PEEP. They may be having fluid transudation. PVPI means fluid transudation in the lung. So there's fluid transudation in the lung. That's why we're doing the CRRT. So most of our patients are going to have hypotension. This is what it looks like once you start the UF. Okay, this is what it looks like from this. Okay, so can I predict whether this patient is one of those patients that is going to have this? It is by doing this. That's when I say when I do CRRT, what do I tell? Like PLR करके देखो क्या हो रहा है. Okay, so when you do a PLR, and you find that there is a rise of cardiac index by 10%. There's a rise of cardiac index by 10%. Say 2.1 goes to 2.4. Okay, 2.6. It goes something like that. Then it actually predicts hemodynamic instability during RRT. Okay, which is a good sensitivity. 77% sensitivity it has. So before you start CRRT, you can actually do a PLR and figure out whether the patient is hemodynamic. So if you cannot do a PLR, you can do some other method. You can do a trial ball challenge, you can do the ETCO challenge, something like that, to actually predict that this patient will have preload dependence related problems. Clear? This is one thing. So this is something that you could do. Other thing is you could reduce the UF, isn't it? You rather than giving this big amount of UF, reduce the UF. If you reduce the UF, obviously the amount of problems that are going to occur will be much lesser, isn't it? So reduce the UF. Don't keep it on the higher side, right? So hemodynamic instability, the first thing is prevent it. Okay, and how do I prevent it? I will first have a conservative UF net. My UF will not be 2000 and 1500. I will have a conservative UF net, and then I will look for preload dependence. If I look for preload dependence, and then if there is preload dependence and UF net I am keeping conservative, then I will reduce my UF net further. I will reduce my UF further. I will not keep it at the UF net that I decided. And if it is not preload dependent and there is hypotension, what will I do? I will start vasopressors. There is no alternative here. Okay, I will start vasopressors even prior if in such cases. Okay, so that's about excess ultrafiltration. Clear on that? Now the other cause that we will talk about is the cardiac cause. Now, in a study that was done in Scandinavia, there were so many patients that were there. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 patients were studied on CRRT. And what did they find? Within 4 hours window, many of them developed hemodynamic instability. Okay, so there is a lack of benefit over intermittent modalities for certain. Okay, there is a lack of benefit. Okay, with respect to that. Now, what about temperature alterations? Now look at this. Now on the CRRT machine, you do have a temperature probe. You can actually change the temperature. You can make it 35 to 38. So look at this over here. What is happening? So this is hemodialysis. Okay, and what you're looking over here is temperature of 35 degrees. This is 35 degrees. Okay, whereas the big dots are 37 degrees. And what you're looking over here is MI, unaffected regions, by strain pattern. Okay, they're looking at MI by looking at strain pattern. On the echo, you can do a strain to figure out which part of the heart is not doing well. So that is what you're looking at, strain pattern over here. Regional volume, basically you can consider it as regional volume abnormality. And so they looked at these patients, these 10 patients that they looked at, different years, different causes of end-stage renal functions. And what they found was if you were at lower temperature, the strain pattern in the heart is actually not very high. The segments that are having strain are actually reduced when the temperature is on the lower side. So definitely to mitigate the cardiac cause, you may want to keep the temperature at a lower level. Okay, I need to keep the temperature at the lower level. Alright, very clearly it is shown even in this that the ejection fraction also, if you see this at the peak, it remains on the higher side. At the peak of dialysis, remains on the higher side. Okay, if the temperature is on the lower side. Clearly indicating on even the BP here. So the systolic blood pressure has remained on the higher side when you have kept the temperature on the lower side. That is why when we are doing CRRT, what do I say? Okay, keep the temperature low, I always do that. I keep the temperature low because I just don't want to have hypertension. Right? So you keep the temperature low, so I don't like to warm up a patient in CRRT. Have you seen me warming up a patient in CRRT? No. Why? Because I want to keep the temperature on the lower side, right? 35 degrees, right? So this is what it is. So this is clear from number of studies that have actually said about this temperature. In fact, this is another study that was done where again, those patients who were cold, the systemic vascular resistance index is high. Those patients who were cold, right? So those patients who were cold had a systemic vascular resistance indexes that were on the higher side, clearly showing that even the systolic blood pressures are higher side, and there were two temperature periods, one at 38 and one at 36 degrees. They did two groups of patients, randomized them, and they found out that systolic blood pressure was on the higher side when you actually had patients with temperature of 36 degrees. Clear? So keeping them 35 to 36 degrees on the CRT makes a lot of sense, definitely. So you've got another method how you can prevent hypertension. Keeping them at 35 to 36 degrees, or if the patient's temperature is whatever it is, keep it 0.5 degrees lesser than that. Okay, if the temperature is 35, make it 34.5. If the patient temperature is 38, make it 37.5. So keeping them lower is always a better idea. Okay, you can't keep it very, very low. That can cause DIC. So that's about the cardiac cause. Now let's see about QD, QR related. Now QD is dialysate flow, R is replacement fluid. Alright. So does the composition of the dialysate or replacement fluid even matter? So sodium, potassium, calcium and buffers. These are four things that are there in our replacement fluids. Okay, so lactate, if you have a replacement fluid that has lactate, it may exert negative effects on metabolic parameters and on hemodynamic parameters. In critically ill patients, the conversion of lactate to bicarbonate is reduced. So normally when you give lactate, nothing happens. Lactate is a fault. Lactate will convert to bicarbonate, isn't it? So the conversion of lactate to bicarbonate, however, in critically ill patients are kind of very much diminished. So it's not a great idea to give a lactate-based fluid. Okay, liver failure has issues with lactate. Most of our patients will have shock liver and things like that. So lactate has to be converted to bicarbonate in the liver. That will not take place. So having a lactate-based solution may not be a great idea. Lactate causes an increased protein catabolic rate also. Even nutrition-wise, it goes problematic. And an increased LP ratio can actually impair oxygen delivery and left ventricular function. This is responsible for hypotension, isn't it? Left ventricular function. So that way, if you look at the whole thing, if increased protein catabolic rate means the heart is going to work more to actually cause more burning of protein. Okay, the overall condition is such that lactate may not be a great idea, and that's why we switched to a bicarbonate-based fluids. Right? Is bicarb the answer? So this is one study that was done in international 20 years ago. Okay, that's the reason why bicarbonate solutions were introduced 15 years ago. Almost 10 years ago, bicarb solutions were introduced. 117 patients on CVVH for AKI, open randomized multi-center study was done, and they looked at around 61 patients in lactate group and another 62 patients on bicarbonate group. So they used two kind of fluids, okay, lactate and bicarbonates. So this is the one we use now. We use the bicarbonate lactate, multi-big we call it, right? And we have the other group that had lactate. So if you look at the composition, look at the bicarbonates here, 35, whereas there is no bicarbonate in this second fluid that you have over here. Right? There is no bicarbonate in the second fluid, whereas lactates are there in the other. Okay, what they found is that frequency of cardiovascular events were lower when you actually use bicarbonate based fluid. Okay, so very clearly after that there were 3 more studies that came in. After that particular, or before that there were 3 studies that actually said the same thing. And when you look at a Cochrane analysis, what we find is that in these 4 studies that they looked at, these are the 4 studies that we just now showed you. These are the 4 studies, 1, 2, 3, 4. They put all these 4 studies to actually look at this. They did not provide any advantage in terms of mortality, it looks like. There was no mortality, but bicarbonate buffered dialysis solution reduced cardiovascular complications. So there was a change in cardiovascular complications and hypotensive events. Clear? So there is definite some evidence of not causing harm, but obviously there is it looks like one study at least actually shows benefits. So what about calcium and potassium? So we talked about bicarbonate, now sodium, potassium, calcium is also there. Serum calcium has impact on hemodynamics and other outcomes. Increasing dialysate calcium may be a viable strategy to reduce HIRRT. Okay, that means increasing dialysate calcium. So sometimes you see, I tell you add calcium. Using that dialysate, I say you add 10C calcium, 5C calcium, 4C calcium. This is based on that. It's based on that okay, there's hypertension, let me increase the dialysate calcium. However, this needs to be studied further in critically ill patients. Till then, I'll keep the calcium on the higher level. So if it's 9 to 11, if its sinus calcium is 5.5, keep it at 5.5. I won't keep it at 4.5, which is normal. Okay, I'll keep it at 5.5. So, however, in CRRT, this data is still warranting. However, we practice it like this. We practice it like this where we keep the calcium on the high side because I don't see there is any harm in doing that. Right? What about the mode? So we have multiple modes, CVVH, CVVH, DF, all these modes are there. So does it really matter? So they looked at 19 studies, RCTs, and they did find no difference in the modes when they actually looked at. So if you are CVVH or CVVHD or CVVHDF, it doesn't really make a difference unless the patient has got sepsis. Unless the patient has got sepsis. Why? Why Vidya? Why sepsis?
Sepsis.
Why would it make a difference in sepsis? The mode matter. CVVH versus CVVH, maybe CVVHDF, will it matter?
So
Why?
There are changes in vascular permeability.
No. It is about clearance.
It will-
Cytokines. Yeah. So cytokines are middle molecules. So we described small molecules, middle molecules. So middle molecules are clear maximum which? Convection. So the matter will make a difference if you're going to use convection in sepsis patients. You use convection in sepsis patients. You got the point, huh? So convective clearance removes pro-inflammatory larger, middle molecular weight mediator removals. That's why you see in some patients in which we have done ultra high volume hemofiltration. Yet some patients which we have done ultra high volume hemofiltration actually gets these patients out of sepsis. Okay, at least gets off the markers of sepsis like cytokines and things like that. Right? So maybe in sepsis is something we use convection. Okay, the mode does make a small difference. Okay. Now what about vasopressor clearance? This is something very important. It's a technical problem. Now what is the technical problem? I discussed it last time. What is the technical problem? Vasopressor. So sometimes what happens, we put the line here and second line here. We discussed this last time, right? So what happens over there?
So if we have put in the central line on the left side and the CRRT catheter on the right
Which is
side.
completely wrong. When you do it in the morning, I come and say, what the hell have you done? I'm preserving this side for, it doesn't make sense. Why it doesn't make sense?
So whatever infusions we are doing from the left IGV, they're all removed from the
With convective clearance, it's just going to come out. Doesn't make any sense, or it doesn't make any sense. It's illogical and completely insane to do something like that. Okay, so definitely that's a technical problem. It's something that we should never do. And rapid oncotic shifts, by definition, is rapid. It is never going to occur in CRRT. Where is this rapid oncotic shifts are going to occur? It is in hemodialysis. Similarly, dialysis blood flow doesn't make any difference. So tomorrow, if there is hypotension, it doesn't mean I need to reduce my dialysate flow because it doesn't do anything. You understand? So dialysis blood flow doesn't do anything. So no role when it comes to CRRT. No role at all when it comes. So now if I put everything together, to understand how to prevent hemodynamic instability in RRT, what would be my flow chart? My flow chart will look like this. First is prevent. My first thing will be prevent it. So let's go to the same thing that we discussed. We'll first conservatively decide my UF net. Okay. The next thing I'll do in this case is I will do a PLR to understand payload dependence. And after doing the PLR, either it will be positive or it's going to be negative. When it's positive, I will reduce my UF because I know this category of patients is going to have hemodynamic instability. Okay, but if there is no preload dependence, I may start a vasopressor during the hypotension or just prior to that hypotension that is occurring. Okay, I may start a vasopressor because there is no point of doing this. You understand? There is no point of reducing the UF here. Why? Because there is no preload dependence. There is no point. It's not going to change anything. You understand? So what I do, I put a vasopressor here. Now I will regulate my temperature. I will keep it 0.5 degrees from my actual temperature. Okay, or I will keep it at 36. One of the two. Right? This is the second thing that I will do to prevent hemodynamic instability. The other thing that I will do is I will use bicarbonate based fluids. We just now discussed why. We discussed why bicarbonate based fluids will make a big difference over here. Alright. And then I will start CVVHDF when it comes to sepsis because I want convective clearance. So if I have sepsis on background, I will use convective clearance by using CVVHDF as much as possible. And more importantly, there is optimal monitoring that is required in these cases. When I do all of these things together, maybe I may avoid hemodynamic embarrassment or probably treat it better than if I don't think about it, right? Alright, so this is any questions on hemodynamic imbalance CRRT? Any questions? Any questions on this? Huh?
Sir, in her slide, she had mentioned that in decreased vascular tone,
So
reason
classically-
behind was increased calcium in diastole.
No. So any patient that is in sepsis will have mitochondrial dysfunction at the micro level. Okay. Today your blood pressure is normal doesn't mean you are normal. Okay. My blood pressure is macro perfusion. Micro perfusion is down at the cellular level. So most of these patients have got autonomic dysfunction as well as problems with respect to vascular tone. That's why they are vasodilated. They are vasodilated. They have got products that are causing their system to get vasodilated. So the vascular tone is high. That's why that's why one slide of mine mentioned critically ill patient. A critically ill patient has this problem. Their vascular tone is down. Since their vascular tone is down, they have a high chance of having hemodynamic embarrassment. So in that case, I will still do the same thing. I will do my PLR. I will see whether it's fluid responsive. If it's fluid responsive, I'll not give high UF. I'll probably conserve my UF a little bit. But if it is not fluid responsive, I'll just start a vasopressor. There's nothing else I can do, because at the end of the day, if my circulation is kind of dilated, if my entire system is dilated, I need to constrict it. As simple as that. Unless I constrict it, there's no point. You understand? You're starting a hemodialysis on that will definitely have a problem because of all the issues that's coming over here. This is specific for CRRT. Okay, there's a small difference when you do with intermittent hemodialysis and when we do intermittent hemodialysis, we'll discuss that. This is CRRT. Okay, anything further on CRRT? On hemodynamic embarrassment? So you can actually refer to the CRRT lecture that we